lead webinar tonight on a how-to session for contrast echo. Oops. We want to thank our institutional sponsors. We have Seattle Children's, Lucille Packard Children's Hospital at Stanford, Nemours Children's, Cincinnati Children's, UK Healthcare, Kentucky Children's Hospital, Ann and Robert Lurie Children's Hospital, Chicago, Akron Children's, and Rady Children's as well. So this session, we have our highlighted sponsor, which is Seattle. And is Dr. Young on the call? Okay, well, we have Dr. Nick Brown here from Seattle as well. So Dr. Brown, if you want to go through these slides in the next 2 minutes, that would be great to highlight Seattle.
Okay.
And just let me know when you want me to forward the slide.
Okay, you can go ahead. So we put together a few slides about our team. So we do have 17 pediatric cardiologists. We have 36 sonographers, and we serve a pretty wide geographic area. We call it the WWAMI region, but it's sort of the Pacific Northwest. All of our regional sites are IC accredited, and then we passionate about QI work. And then we have also educational opportunities for the non-Seattle children's sites in the region. So we have a lot of partnerships, especially with the local sonography school, which is, there's been a lot of back and forth with education with them, and then a lot of them, that are hired to join our team. You can go to the next slide. We do have 3 new faculty members. So Katie Verk, Eddie Gearhart, and Surbi Gupta. Katie was a fellow here. Eddie recently joined us from Boston, and then Surbi from UCSF. And so we're very excited. A couple of them in cross-sectional imaging, and then Katie Verk more for the fetal focus, but they've been great so far, and we're excited that they joined our team. And then please see, Perez Kersey is going to be our 4th-year imaging fellow for next year. So we do have a 4th-year imaging program, and we've really enjoyed training them. Have gone on to be very successful. So, next slide. And then just a highlight of some things that we've been working on as a lab, some innovations. One of our 3rd-year fellows for this year, Rob, has been working on machine learning and taking fetal echo data sets and measurements and trying to improve our prediction of coarctation based on a lot of prenatal measurements and angles. And then Katie Verk has also been looking into some of that work in terms of fetal coarctation prediction. We have several faculty that are participating in Fetal Heart Society projects. Bhavna Arya is a study PI for some recently published Fetal Heart Society papers, and then looking into STS collaborative study on fetal echo triage during COVID-19. And then a couple, there's a multi-center study, and then involvement in the PHNZ score studies. And then we've also been looking into T discrepancies, sort of pre and post assessments of when we might be missing things or where there's areas for improvement. And the next slide. And then a couple of focuses on 3D echo and some of our cross-sectional imaging. So one of our faculty members, Brian, has been looking into using VentriPoint for 3D assessment of volumes, especially seeing if we can translate some of that to our single ventricle population, and then also using it in pulmonary hypertension. And then one of the things that I've been working on here is using some VR software for mainly using CT and MRI data sets, but also looking into echo to see if we can do some pre-surgical planning and some baffle visualization with the surgeons. So that's been great for visualization and for our preoperative planning. So I think that's it for that.
That's it. Yep. All right. Thank you, Dr. Brown. Okay. Just a reminder, everybody, you can follow us on social media. There is lots of different ways that you can follow us as well. And I'm going to hand it over to my co-chair, Carolyn Wilhelm, for the rest of it.
Thank you, Dawn. You can go to the next slide.
Oops. Must not have put on there. Well, There you go.
That's okay. So as Don mentioned before, our evening session today is a how-to session on contrast echo. I'm going to introduce our first moderator, and that's Ray Lorenzoni from Connecticut Children's, who is a member of our SOPE Education Committee.
Thank you, Carolyn. Appreciate it. I'll introduce my co-moderator tonight. You already heard from him. It's Nick Brown from Seattle. Dr. Brown's an assistant professor and non-invasive imager at Seattle Children's Hospital and Washington School of Medicine. He's got a particular focus, as you just saw, in advancing our understanding of congenital heart disease using 3D echo and CMR. He also appropriately helped establish the contrast and ultrasound enhancing agent program at Seattle. As part of his clinical work, he's utilizing 3D data sets and virtual reality to increase understanding of CHD. And he'll introduce our first speaker, or our co-speakers, that is.
So I have the pleasure of introducing Jarrett. Jarrett Linder is a friend of mine from training and helped teach me a lot of things that I know about 3D echo and ultrasound enhancing agents, but he is assistant professor of pediatrics at Northwestern University and practices at Lurie Children's Hospital, expert in ultrasound enhancing agents and in 3D echo and procedural imaging. So very much looking forward to hearing updates about what you guys have been doing.
Yeah, and I'll introduce Jen Acevedo as well. We were lucky enough at Connecticut to actually host Jen, and she helped us improve our workflows around contrast enhancing agents, so also a very appropriate speaker for tonight's event. She's a clinical educator at Lurie Children's Hospital, as you saw, and she's a past graduate of the ACE Leadership Academy, active in both ACE and SOPE. She also works with high school students in underserved communities in Chicago and speaks to students about allied health careers and serving as a mentor. And in her spare time, she enjoys scuba diving.
Right.
Yeah, take it away.
Thank you. I'm going to go ahead and share my screen now. And sorry if you guys see all my backgrounds. You could see the presentation now, can you?
Yep, that's good, Jen.
All right. So thank you for that introduction. Hold on, sorry, I just needed to hide the meeting controls. All right. Jarrett, do you want to start with a quick introduction about UEAs?
Sure. Today, there's a few different things that we're going to discuss. First of all, thanks so much to Nick and to Ray and the rest of the organizing committee for inviting us to speak today. We're really excited to talk to you guys. So Jen and I actually run our ultrasound enhancing agent program along with a nursing colleague, Christy O'Connor, who's not available tonight. But we kind of work together to get this program up and running. And we've currently done over 200 ultrasound enhanced agent studies in the last couple of years since the program got up and running. So Nick was thankfully one of our fellows during that time. And so we were able to teach him. And then Jen does a lot of outreach at other institutions. And so thankfully she was able to go out and help Connecticut Children's as well. So just a brief introduction for what we're going to be talking about tonight. So we're going to review the historical context of ultrasound enhancing agents in cardiac imaging just briefly. We're going to talk a little bit about the FDA approval status for pediatric use of the different agents that are on the market. So Lumasan, also known as Sonoview outside of the United States, was FDA approved for ultrasound enhancing agents for pediatric use back in 2016. So that was initially to look at hepatic evaluation. Currently, it's used also for cardiac opacification with the same indications as adults. So it's mostly for left ventricular endocardial border delineation, and that came on the market in 2019. Definity actually became FDA approved last year. So in March of 2024, so we're coming up on a year now, it finally became approved for use in pediatrics. And then Optisan is the other agent that's on the market, which is currently not FDA approved in pediatrics. However, I know that they recently completed a clinical trial related to use inside of pediatrics, and so should be FDA approved probably within the next couple of years. And then we're going to review some of the challenges that people have kind of noticed. So I think there are several different issues that come up related to using ultrasound enhancing agents in the pediatric population. And so Jen and I are going to try to highlight some of those.
So sorry, go to the next slide. So administration protocol. At Lurie Children's, we do use Lumason, and it is weight-based, so it's going to be 0.03 mics per kilo. But when you're starting your UEA program, things that you do need to consider is one of the big things that is a challenge is venous access. In the adult world, people do UEAs all the time, and it is written that it is in the scope of practice for sonographers to start IVs in the adult side of the echocardiography lab. And this is a hard pill to swallow. I think, when a child's been coming to us for their whole life and all of a sudden, without warning, the cardiologist goes in the room and says, we want to start an IV so we could get a better echocardiogram. It's a hard pill to swallow. So those are things that you want to take into consideration. Another thing is going to be timing, the timing of the administration. It does add time to your workflow. So those are things that you have to account for. And with adding time, that's going to decrease productivity. And so if I do have any lab directors on a call, again, things to think about. And then once we do start the administration of the UEA, there are a lot of other technical considerations with image optimization, understanding how to switch into contrast settings. And so there are some challenges that we face when we're starting these programs. Jarrett, do you want to take this one, or do you want?
Sure. So when we're thinking about safety considerations, I think this is probably one of the most important issues that has come up inside of a lot of pediatric labs. So most of the data that's readily available is for use in the adult population. And so in the pediatric population, while we extrapolate a lot of those numbers, we don't really know exactly what the numbers are inside of the pediatric arena. And so because of that, at least our lab has adopted some surveillance following administration. And we've also incorporated some practices directly into our lab to sort of help with some of the anxiety related to parental concerns, as well as healthcare worker concerns. So some of our sonographers have concerns related to potentially having an adverse reaction, potentially having an allergic reaction. And so we've sort of put a lot of things in place to kind of help with that and help alleviate that. One of the things we also always want to think about is risk-benefit assessment. So we want to make sure that if we're going to administrate a new medication, or in this case, an ultrasound enhancing agent, we want to make sure that the benefit for that is real, and so that we're actually going to get something out of that. Or, can we potentially prevent radiation exposure by potentially using an ultrasound enhancing agent? Are there other things that we can use? And then similarly, we use a monitoring system. So we monitor our patients for 15 to 30 minutes after they're receiving ultrasound enhancing agents. And that's either in the inpatient setting or in the outpatient setting. The way that we sort of do that is dependent on whether or not patients have a clinic visit that's going to follow. So usually if they have a clinic visit that will follow 15 minutes after they've had a UEA administration, we'll basically send them off to their clinic visit where they're continuing to be monitored for at least the next 15 minutes. For patients that have an echo only appointment and we're using an ultrasound enhancing agent, we'll monitor them for a longer period of time, so about 30 minutes inside of the room. So as Jen was mentioning before, it's really important to think about that and build it into sort of what your echo lab schedule might look like. We utilize slightly longer slots for these patients, and we kind of time them around a time where it's easy for it to sort of fit into our echo lab schedule.
So then this is going to be more on the administrative side of things, the cost considerations and the reimbursement. It does cost. We have nursing involved. So there's the IV access part, that team involved. And so there is an investment. But again, sometimes, especially like with our Duchenne's muscular dystrophy patients, we definitely see the benefit in doing this with spending the money for the staff, the room, etc. in our lab, we developed an imaging protocol to standardize everything and understanding that this is something new. Again, I mentioned earlier, like in the adult world, you do these a few times a day, maybe 3/4 of your patients get a UEA. But in the pediatric world, that's just not the case. And so we figured we needed a protocol. And then as going with that, with quality improvement metrics, we do present these cases. We try to do it quarterly. Maybe it doesn't happen so consistently, like on a quarterly basis, but at least a couple times a year, we do review these cases to look for areas where we could improve. And then last but not least, talking about a consent process. When we first started, we weren't really sure, did we need a consent? Did we not need a consent? But the consent is covered under the consent to treat when the patients come to the hospital. However, one thing that we do need to lean on the UEA companies is as they're getting these FDA approvals, they need to come up with a little bit more pediatric friendly parent education so that the parents can take these pamphlets home, read about them, and understand a little bit more as to why we're using this UEA. All right, let's jump into some cases. I think this is why you guys are here. All right, so this is a patient here that is a dilated cardiomyopathy and had LVAD placed. And so because he has the LVAD in, I purposely put this picture here. This RV function actually doesn't look that bad when we're looking at it on 2D echocardiography, but we opted to do a UEA just to make sure that what the RV function was doing. And you could see that the RV function isn't really as robust as it looked on the transthoracic echocardiogram. So this is one where this is a 4-chamber heart. This is, although we're not looking at left ventricular endocardial border definition, we are looking at the right ventricular endocardial border definition. So I think that this is still going to fall within that, under that umbrella of the endocardial border definition. So kind of on label usage.
I think just to add to that, when you're focusing on that right ventricle, you can clearly see the endocardial border, just like Jen was mentioning. It means that you can measure a fractional area change much more easily using the ultrasound enhancing agent. We actually use this routinely in almost all of our ventricular assist device patients. And I think there's a couple of different reasons why we use it. So one is for evaluation of the right ventricle, usually for function, like Jen's mentioning. And the other one is for thrombus evaluation. So it's not uncommon that we'll see something inside of the LV cavity where we're concerned about thrombus potentially. There's a lot of artifact related to the cannula that's in place. And with ultrasound enhancing agents, a lot of times we can see the apex of the heart much more clearly. There's actually a case that we had earlier today where there was a large thrombus inside of the left ventricle, and we used ultrasound enhancing agents to better visualize it. Patients still wound up going for a CT later, but did help in terms of determining what our clinical course was.
All right, now we're going to review some off-label ways to utilize a UEA in patients with congenital heart disease.
So this is a paper that I was a part of. It was one of my big fellowship projects when I was at Children's Hospital of Philadelphia, and we were focused on utilizing ultrasound enhancing agents in Glenn patients, so in superior cavopulmonary connections. So Jen, you can advance. I think really what we did was we took any patients that were hypoxemic and prior to them following their Glenn during that hospitalization, and prior to them going to the cardiac catheterization laboratory for angiography, we actually performed echocardiograms and we used ultrasound enhancing agents in order to evaluate them. And so the image on the left, you can clearly see with color flow, the branch pulmonary arteries and the SVC anastomosis to the right pulmonary artery there. But when the color is not there, it was very challenging for us to see the picture. And so the image on the right of your screen is utilizing ultrasound enhancing agent. One of the things that's interesting about using it for blood vessel opacification versus using it for for evaluation of like a left ventricular pumping chamber or a right ventricular pumping chamber is that when you first initially inject the Lumason or the Definity, what you'll notice is that you get the best visualization of a blood vessel that you're evaluating on immediate injection. And so one thing that's really important to consider is your point of access. And so this is very similar to a first pass effect that I'm sure Nick or Ray could talk a little bit more about. But that's actually follows the same sort of pattern and methodology for utilizing ultrasound enhancing agents. And so you really want to make sure that you optimize your image before you're injecting. And then you want to have the clearest picture, because what often happens immediately afterwards is that you can see here that big neo aorta starts to light up very quickly inside of the picture. And not just that structure, but a lot of times very many other structures will start to light up very quickly. And that will actually make it a little bit more challenging for you to visualize some of the structures that you're really focusing on. In this case, we have really nice opacification and we don't have any shadowing artifact. But sometimes if you give the ultrasound enhancing agent a little bit quickly, you can actually get a lot of shadowing of structures that are behind it. So it becomes harder to see the branch pulmonary arteries.
Jarrett, in the interest of time, I'm going to skip past these and
Sure.
go straight to the IVC. All right. So this next clip that we're going to look at that first pass filling that Jarrett was talking about. This is a patient that is filling Fontan with PLE that we've all seen this, where you get like this nubbin down in here, but we weren't really sure, given the patient's poor function, if that was truly thrombus or was it artifact. So we went ahead and did a UEA, and this is that first pass filling. And so here you're going to want to give the Lumason just a little bit faster so we could really fill that IVC. And you're going to see right here, it lights up white. And so that's all the UEA. You're also going to notice that liver lights up like a Christmas tree as well. But that UEA, we didn't see any black in there, so that ruled out any sort of thrombus. Now we were able to rotate on this picture and look at the IVC in cross section as well. And we don't see anything there to lead us to believe that there is a thrombus.
And that was important because the primary cardiologist was interested in starting anticoagulation for this patient. And so once we were able to prove that there was no thrombus, we were actually able to change the management plan for this patient.
The next cases we'll look at.
Oh, I don't know why that was.
Here we have a patient.
Oh my gosh!
That is a 16-year-old teenage patient that presented.
Hold on, guys, 1
for
second.
hypertension.
And a pause there.
Yeah, I don't know why let's see, I'll lower that. Okay. All right. Well, I guess I already talked about it while I was so this is like I said, a 16-year-old that had a history of coarctation. And what we did was we used the UEA, and I'm fearful to go to the next slide, but we used the UEA for to see if we could compare the CTA to the UEA. Now, I'm going to come out of this really fast. We're just going to pivot because I think I do have audio on this next one, and so I'm just going to mute it. Let's see, how do I do this? There we go. Why is it not letting me? There we go. There. All right. So here you're going to see, this is us with that first pass filling again, and we're going to look at the arch this time, and notice that we don't get any UEA past this area. And so I was like, okay, this is a test failed. However, when we look at the CTA, there we go. Let it rotate. You could see that this was almost a near interruption. There's like a thread of tissue right there. So I didn't feel so bad that we weren't able to truly see the narrowing with UEA. But I think that this is an example of where in the adult world, you have a finite reason why we're going to use this. This patient has poor windows, and we're going to look at that left ventricle, where I think in pediatric echocardiography, we have a larger potential to find other uses outside of what the product's been labeled for.
So we've all had that.
Oh my God. Sorry, guys.
So this is a patient that is
Jarrett, I'm going to lower this one if you want to talk about the coronary artery imaging. There you go.
Yeah, sure. So this is something that we've been exploring with in some of our patients to evaluate what their coronary imaging looks like if we're having trouble being able to visualize it. So typically we will only use this in the case when we're using it for LV or RV opacification, or there's some other indication for us to use the ultrasound enhancing agent. But what we're interested in doing is at the same time exploring some of these novel areas to evaluate. And so this is a really good example. And you can see the right coronary filling really nicely at the top of the screen there, right off of the right coronary cusp, and looks like it has normal anatomy. I think, as we continue to sort of expand this, similarly, we've used it to evaluate branch pulmonary arteries. We've used it to evaluate pulmonary veins. We've used it to even evaluate for potential vegetations on valves and things like that. And so we've really been trying to increase the amount that we've been doing and the kind of indications that we use it for.
All right. I'm just going to lower this one. Sorry. Jarrett, do you want to talk about this one while I try to figure out how to, sorry, this is the baffle assessment.
Sure. So some of our more complicated congenital heart disease patients, or some of the or adult congenital heart disease patients, are some of the more common patients that we'll utilize ultrasound enhancing agents for. And so in this picture, this is the case of an atrial switch operation, or in this case, the patient received a mustard. And we were evaluating for a potential baffle leak for one of these patients. And so as you can see, the systemic venous baffle shown by that red arrow there, sort of showing it entering into that left-sided morphologically right ventricle. And what you can notice is that can much more clearly delineate this systemic baffle inside of this patient. And whereas previously we needed to use MRI a lot of times, or CT, in order to evaluate, in this patient population, we've been very successful being able to evaluate for any kind of intracardiac baffle leak.
All right. And then just in the interest of time, you know what? I'm going to just go to this one really fast in the interest of time. So we have time to take some questions. So I don't know if anybody noticed that when we were looking at that Glenn, there was a 5 megahertz transducer that we had to use. So the important thing to know is, although that these UEAs are FDA approved for pediatric patients, the ultrasound companies haven't caught up. So we don't have our higher frequency transducers that we normally use. We're not able to use those with Lumason or with Definity either. This was an attempt using a higher frequency transducer, and we ended up switching to an abdominal preset. And you could see we didn't destroy the bubbles, but we don't have that nice tissue bubbles interface. So there's definitely a lot of work to be done. Jared, do you want to go?
Sure. So in summary, ultrasound enhancing agents for use in pediatrics is at its infancy. There's many novel applications that we can explore, including both on and off-label uses. And pediatric institutions all need to come together and work to explore new opportunities to utilize these in pediatric patients to allow us to expand our use of UEAs for the betterment of our patients. So that's what Jen and I and everybody on this call is focused on doing.
Yeah, and I'll just add to that. At the end of the year last year, ACE did send out a survey asking about UEA use in labs. And the reason for that survey is they wanted to just get an idea about maybe starting task force and championing, guidelines for us as well. There's a lot of literature. If you go on Contrast Zone, there's a ton of information for adults, but we don't have anything there yet. Thank you.
All right, that was perfect. As you know, we try to stick to time, and the presenters did an excellent job. Thank you for that, despite some of the technical difficulties. But we don't blame you for that. We know how it is. Anyone still listening, just make sure you're putting your questions in the chat or raise your hand. We'll try to see you and call on you. But now it's kind of an open session for those who want to stay to ask questions.
Yeah, so thank you, Jen and Jared. it's great to hear all the, especially how much the volumes have grown and how you've really incorporated this into, part of your protocols. I guess that's one of the biggest questions I have is how you sort of get over that hump of, you mentioning barriers with IV access or concerns about, contrast reactions. But in terms of how you get, incorporate it into protocols where you sort of gain momentum and build awareness. And, I know even when I was there, was sort of incorporating it into some of the actual clinical reports that maybe on the next study, like this patient could benefit from a UEA agent. But I guess were there other specific things that you feel like have helped really, propel you guys forward in terms of getting more patients scanned and getting more people familiar with it?
Yeah, I would say it was a labor of love. So it was a couple of us that were comfortable doing it. I would say that Jen and I did every single study in the very beginning, which you could probably remember as that was sort of taking off. And I think, as we were able to show people what these pictures look like and how we could answer certain clinical questions, and especially in some of our sickest patients where it was really hard for us to move them to an MRI scanner or a CT scanner. And I said, hey, I think we can try this and we can do it really safely. We can monitor the patient really closely afterwards. As the surgeons started to see it more, as our CICU team started to see it more, it's actually a very common thing for it to be brought up on surgical rounds now in the morning. So as we're doing our sign out, and it's not uncommon that actually somebody else inside of the room says, hey, did anybody try looking at that with contrast? Because I think we could see it a little bit better. And so it's not uncommon now that people just bring it up. I would say the other thing that was really helpful was that both Jen and myself kind of made ourselves available whenever there was one of these that was happening. And so we've trained up all of our colleagues. So all of our sonographers at Lurie Children's Hospital are comfortable doing it. They know all the settings. We've made several PowerPoint presentations, protocols for them. There's even a clinical care guideline that's accessible through our EPIC, so our electronic medical record, that allows any of the nurses to look it up, any of the providers that are using it, and sort of outlines what everybody's role inside of the room and how they can help us get the study done. And I think that's been really useful.
Yeah, thanks.
Perfect. Yeah. There are a couple questions in the chat which are related. One from Jose Galan and then one from our own Don Park, which I think can kind of go together. So Jose asks, which specific lesions do you believe UAA could become the standard for? And then how do you kind of manage your outpatient schedule to, schedule in IV placements and make time for that?
Could I take the first part, Jarrett?
Go
Are you
for
okay
it.
with that?
Go
All
for
right.
it.
So the specific lesion, it's not necessarily a lesion, but I have to say Duchenne's muscular dystrophy, hands down, it's been a game changer for these kids. Before we had a UEA, we were managing these kids on poor images, especially if they weren't able to get in a scanner. So I think that that's probably the biggest subset of patients that we see benefit right now. But, just like when you're learning pediatric echocardiography, you need to do sweeps and you learn like, oh, I could see this, I could see that. I think that we need to take that same concept and apply it to UEAs. Once you get over the hump and you feel comfortable, because when you first start it, you're just so nervous, like it's going to go away and I didn't get what I needed. But once you get over that hump, when you start doing these sweeps, that's when you could really see, oh, look I could see the pulmonary vein. I could see the branch pulmonary artery. And that's where you start to see, and that's where I think we will start to see where it's more valuable, more relevant to us than it is in the adult world.
I would just add to that, Jen, I think from an outpatient standpoint, certainly muscular dystrophy is a game changer. We can always evaluate these kids' hearts and don't even need them to get out of their wheelchair and have to move onto a bed. They're a lot more comfortable than when they have to sit through an MRI scanner. And our goal is to have them require MRIs less frequently, depending on what the indication is. But certainly if the indication is only for function assessment, we should be able to do that by echocardiography. The other thing that I would add is ventricular assist device patients. So you saw an example today, but often, especially in the immediate postoperative period, it can be really challenging. And the biggest question is usually the right ventricle. We care a little bit less about the left ventricle once we've already put a device inside of it, but the right ventricle becomes really important, as we all know, to fill that device. And evaluating it for function is something that can be really challenging. And so honestly, we didn't show a lot of examples of some of the ancillary views, like some of the other views to evaluate the right ventricle, but certainly we use it all the time from a parasternal long axis, from a parasternal short axis, and apical to really evaluate what that RV is doing. And it's been really, really helpful. The second question was about the timing, right? So this is challenging. I think this is different at every institution. What we've worked on is we have a nurse who is often present for all of these studies, and they kind of serve as our quarterback for these. And what they do is they schedule it. They're present when the patient gets there. As soon as the patient arrives and gets called to an examination room, they will page our IV access team that will come and place an IV. But while we're waiting for the IV to be placed, we will actually start with our scan. And so we'll get all of our prior imaging that's necessary before we're giving an ultrasound enhancing agent. And then once the IV is placed, then we can just proceed with the ultrasound enhancing agent. And I would say it usually takes anywhere between 60 to 90 minutes probably for us to complete the outpatient studies. But it's been it's pretty efficient.
So your goal is to put me out of a job, is what I'm hearing.
My goal is to take some of the reliance on some of the axillary, like some of this other imaging, and bring it back to echo for sure. Definitely.
It's very interesting. I mean, there's the challenge with IV access, but even with some MRI techniques, we can get native mapping, but also just moving them onto the scanner table, and the exam taking a lot longer. So it's interesting navigating like timing of when you would do some of those. I think there are some other people that had questions about, say we've had access to, saline bubble studies, but what is like extra special about the Lumason in terms of the extra benefit you get from using Lumason over just doing a bubble study?
Definitely. Jen, do you want to take that?
I think that the biggest benefit you're going to get is it's kind of a twofer. You're going to be able to rule out a thrombus in the IVC, but then you could go ahead and image a ventricle too and get an idea of what that cardiac function is truly doing. So I think that that's one way of looking at it. And then also, if you're going to start an IV, I think, well, unless we're looking for a PFO, then we'll go ahead and do the bubble study. But I think that because it's so readily available, it's just easier for us to use that.
Well, yeah, that makes sense.
Yeah, go ahead.
I think I know you had alluded to this earlier, that you don't necessarily do dedicated contrast studies for coronaries, but that was one of our other questions from Dr. Schwab. Do you sometimes try to view, what you expect to be unusual coronary configurations, for example, in TGA, if you're looking for a circumflex from the RCA or abnormal branching?
Definitely. There's been several cases that we've had inside of the ICU where we've had difficult diagnostic dilemmas. And so we won't typically use it just for evaluating something that is potentially like an off-label indication for it, where I'm not really sure if we'll be able to answer the clinical question. So typically the patients where we've done that in is if we were evaluating for a thrombus, let's say inside of the SVC, a line-associated thrombus inside of a complex congenital neonate, and then at the same time, we'll utilize the ultrasound enhancing agent to try to look for other things. And so we'll evaluate. We've done it several times in patients that had bilateral flow reducers that were placed to evaluate what their branch PAs looked like afterwards. We've used it for evaluation of anatomic considerations, especially surrounding pulmonary veins. We've utilized it, I think, One of the challenging things about coronary arteries, we showed a really beautiful example of that, but especially in complex neonates, don't underestimate the fact that everything starts to light up and you're looking at something that is very, very, very small. And so it does become really hard to figure out where the border is of the coronary and where the rest of the structures are there inside of the area. And so, because your branch PAs are going to light up, your right ventricle is going to light up. There's a lot of different structures there. And so it can become a little bit challenging.
I was going to ask, I mean, it sounds like all of the MRI, first pass MRI techniques seem, especially in that post-op period where you have a hard time seeing things, there's lots of untapped benefit there. But have you found times where, in terms of the negative or, predictive value of this, you say you do something and say that it doesn't look like there's any problem with the Glen, and then they end up, becoming more desaturated, and you get a CT or you get some other, or a cath, and you find, oh, we actually, missed something or thought it was okay. And, I don't know how much that's happened, but there's some kids where I feel like we've tried it and we just can't get over the lung artifact. It does help, but it just doesn't overcome everything. So I think that's been a little bit of a challenge.
That is a terrific question. We actually have not really had that. Most of the time, like if we were able to either I'll say that I was able to visualize it or I wasn't able to. So there are definitely times where I've tried to use it and I wanted to see a structure, like for instance, a Glenn patient, and there just wasn't a window for me to be able to evaluate adequately. But I comment on the fact that it was unsuccessful. We weren't able to see it as clearly as I would like to. And so we should continue considering other evaluation.
Yeah.
Great. I had one other technical question when we had a couple minutes left. There have been some publications that describe measurement of ventricular volumes as being slightly larger than typical echo measurements, closer to MRI measurements, actually, as has been reported. Is there anything you do to adjust for that?
We haven't really used anything to sort of make an adjustment related to that. I think the volumetric measurements that we're using are very similar to our normal echo measurements. It's just allowing us to see that heart border a little bit more clearly. So we haven't really made any adjustments related to that. I don't really think that there's been a lot of studies there has been adult studies where they've evaluated ventricular function, RV function, and LV function and compared it to ejection fraction by MRI. And those have been relatively consistent, but in pediatrics, it hasn't really been replicated to my knowledge yet. So it's definitely something that's interesting to sort of see. But I think what's more important to me is more the overall number for what our function is, right? Is our function down or is our function look good? Because most of the patients that we're worried about in this case is in the immediate postoperative period. And so it's trying to figure out if there's something wrong that's going on that we're missing and we just don't have the window to be able to visualize it. And now we have another option to be able to see that.
Yeah, I think it's one of the challenges. It sounds like there's still not great post-processing options for 3D imaging either, to sort of, I think you can do like a simultaneous 4-3-2, but in terms of actually post-processing a 3D data set, but I think we've kind of found that you end up measuring farther out into the trabeculations, which is, we sort of do that a little bit more with MRI than we maybe do with echo, where harder to see all the way into the compact myocardium.
I think I completely agree with you. One of the biggest issues that we have with it, because one thing I was really interested in exploring was evaluating 3D ejection fraction, especially of right ventricles, utilizing this. And one of the challenges is related to the software packages available on a lot of the carts. What they're used to tracking is actually opposite of what the imaging becomes. So if you're using contrast mode on the machine, you're actually, what is becoming bright is actually your blood pool, your blood space. And the software technology is looking for the opposite. So it's looking for the actual endocardial echocardium, the myocardium to actually be the bright part and the blood space to be the black part. And so it becomes really tricky when you ask it to track appropriately. Although we've spoken with several industry partners who are kind of supposedly working on this in the background, but more to come related to that.
Yeah, I think
Real quick, just
go ahead.
just before we run out of time, not on 3D echo, but one of the ultrasound vendors did develop technology to be able to do strain on contrast images. And I thought that was a game changer, especially because Duchenne's is one of our biggest populations that we are using it in, and we can't do strain on these patients because we're using a UEA. So we did demo it and it worked pretty well. So, you know, ultrasound vendors are always developing the newest things. So maybe we'll see something with 3D echo and UEAs at ACE this year. Who knows?
All right. Thanks, Jen and Jared. I think that's our time. Dawn and Carolyn, do you want to take us away?
Yes. Thank you guys so much. That was such a great talk. Again, thanks to our institutional sponsors. If anybody is interested in their institution being a sponsor, we have an email address there, and then you can have your institution highlighted as.
And then our next speed session is going to be cardiomyopathy and diastology in April at this same time, 8 p.m. Eastern Standard Time. Thank you, everybody, and have a great night.
Thank you.
Take care.
Bye.
Thanks, everyone.
Yeah, thank you.